what you basically have is a three-component molecule where the antibody will recognize a specific area on the tumor. There's a linker molecule which will be stable in the circulation and that is cleaved once the complex is ingested into the cancer cell. And then there's the payload or warhead, which is a chemotherapeutic agent, typically something that may be extremely toxic if you administer it by itself, particularly MMAE we know can be pretty toxic at the levels that are needed to achieve cytotoxicity. And it has to have a specific mechanism against the tumor type. So the first drug I want to discuss is Enfortumab vedotin, which is an ADC that's comprised of an antibody to Nectin-4. Nectin-4 is overexpressed in metastatic urothelial carcinoma. In fact, more than 90% of specimens will express this. It's linked to MMAE, which is an antitubulin agent, and this, of course, enters the cancer cell, is cleaved, and then MMAE can cause its cytotoxic effect. So we embarked on a phase 1 trial of Enfortumab vedotin in patients with metastatic urothelial carcinoma. In fact, this was also performed in patients with metastatic lung as well as ovarian carcinoma. And we had 3 dose expansion cohorts with approximately 15 patients per cohort. And then we went over to a final phase 2 cohort at 1.5 milligrams, 2.5 milligrams per kilogram. We originally were looking at patients, or at least looking for Nectin expression, and then we found that 90% of these specimens had it. We dropped that as a requirement for patients. And this is the screening of Nectin. 97% of the samples that were examined showed Nectin-4 expression, and this was fairly high, median H score of 280 out of 300. And as I said before, we don't require this as a prerequisite for entry. So these were patients who were heterogeneous. There were patients who had failed one prior treatment that included checkpoint inhibition therapy. As we can see at all dose levels from 0.5 milligrams per kg to 1.25 milligrams per kg, we do see responses. In fact, we had 2 CRs out of these patients. So what are the different characteristics that we've seen in our phase 1 trial? So there doesn't really seem to be any clear dose response effect. It's very, very difficult to see this from the data, but overall, 41% of patients had an objective response. At the recommended phase 2 dose, 1.25 milligrams per kilogram, it's 53%. And as I mentioned before, we had 2 complete responses at the 1.0 milligram per kilogram and 1 at the 1.25 milligram per kilogram level. Now, when we start breaking this up in terms of prior treatment, if you look at those patients on the left who had prior checkpoint inhibition therapy, 44% of patients at all doses responded. At the recommended phase 2 dose, it was 47%. Prior taxane-based therapy, 60% at the recommended phase 2 dose versus 41% at all doses. And then the interesting thing, I think, is those patients with hepatic metastases, 60% responded at 1.25 milligrams per kilogram and 47% at all doses. Now, interestingly, we have one woman who has now been on treatment for more than 2 years. She presented with hepatic metastases. She is active. She is a real estate agent. She's still working. So it is really possible to maintain an excellent quality of life while you're on this treatment. So this drug was granted breakthrough status by the FDA on March 26th of this year. There's a large phase 2 trial of 160 patients, which is actually rapidly accruing and probably will close very shortly, in patients who have prior checkpoint inhibition therapy. This is designed to get the drug initially approved through breakthrough status. There is a phase 3 trial, which is just opened recently, of Enfortumab versus dealer's choice chemotherapy in patients who've had prior checkpoint inhibition therapy. And in those patients who've had no prior therapy, there is a phase 1, phase 2 trial that is combining Enfortumab with pembrolizumab as frontline therapy. So the question is, of course, is there an interaction between IO and Enfortumab vedotin? We may see that later on through randomized trials. But this is the schema for the drug's approval. So there are other agents that are being evaluated in urothelial carcinoma. Secukinumab govitenin, or IMU 132, I'll just simply use that term. It's a lot easier to use. It's a complex that recognizes TROP2, which is a pan epithelial antigen with broad expression in different tumors. As we see with Enfortumab, the antibody binds to the outside of the cancer cell. It's internalized, and rather than using a tubulin agent, it uses SN38, which we know is a topoisomerase inhibitor. And you can again deliver high drugs, much higher than you can with just simply using irinotecan, which is the prodrug. So a phase 1, phase 2 trial has been performed again in various solid tumors. The cancers of interest that were looked at in this trial included non-small cell lung cancer, triple-negative breast cancer, and urothelial carcinoma. This was given on a day 1, day 8 regimen every 21 days. Enfortumab is given day 1, day 8, day 15 every 28 days. And doses range from 8 to 18 milligrams per kilogram. So this is from the urothelial cohort. The median age was 69. Predominantly those patients with lower tract disease, 84% had lymph node metastases, and 47% had a low hemoglobin. These were a heavily pretreated group of patients with the predominant chemotherapeutic agents being used prior cisplatin or carboplatin-based therapy. Okay, these are the adverse events. Diarrhea, neutropenia, as well as febrile neutropenia were the ones that predominated in this particular study. Now, this is a small number of patients, but there are objective responses. These are all partial, so 7 of the 14 patients in the preliminary experience that was presented at the AACR had a partial response. 3 patients had stable disease. These were all confirmed. The number is lower of confirmed responses in the Enfortumab vedotin because that's a trial in progress. The number is actually going to be updated at the ASCO meeting in a couple of weeks. So again, high response rate. And then, of course, when we start looking at the durability, these also have some degree of durability as well. And the median progression-free survival is about 7 months with this particular compound. This is, again, what we see again with Enfortumab vedotin. So it's a novel ADC. It's active in urothelial carcinoma. And as we saw with Enfortumab vedotin, TROP2 is not a pre-selection criteria. And at this point, it's not clear what the plans are going to be for this particular compound, where it's going to go as far as other trials are concerned. So in conclusion, ADCs are active in refractory urothelial carcinoma. But one thing I can also say is that these particular agents do not cross-react. I'm probably the only person who's treated patients with both of these agents, and we've had patients who have been treated with both agents sequentially, and they do not seem to have cross-reactivity. So there's room for development of both of these agents, and they may actually have complementary activity since they have different targets as well as different warheads. So there are phase 2 and phase 3 trials which are underway to grant FDA approval to Enfortumab vedotin, and the whole plan, I think, with IMU 132 is still under discussion, and we'll see where that goes in the next couple of months. So I'll stop there and answer any questions you have. Yes?
Thank you. Very exciting data, especially with the Enfortumab vedotin. I had a question, and hopefully you can tell me. What was the median time to response with the drug, especially in the different populations and also in the checkpoint refractory group?
So the median time to response is fairly quick. Usually, I don't have that number, but just my impression is that usually when they responded within the first assessment, which was 8 weeks after their initial presentation. We've had some pretty dramatic improvements in performance status. In fact, a couple of patients we've treated on the phase 2 trial were symptomatic with pain. One patient had a large pelvic mass, which is practically gone at this particular point. A second patient who had a renal pelvis tumor, which was causing her back pain. She's not yet been assessed, but the pain's also gone as well. So, yeah, the time frame that I've noticed the pain improvement has been within about 2 weeks. So this works rapidly in these patients, and I think that the real question is how does this interact with the checkpoint therapy that's been there previously? We really don't know. But I think again in our phase 1 experience we saw separate independent activity in those patients who had not had prior checkpoint therapy.
Dan, I have a quick question. All these ADCs, they use different receptors, different chemotherapy backbones.
Right.
So technically, they are not overlapping, right?
They're not
Both
what?
can be, so they are not overlapping as
Right, exactly.
similar to like PD-1 inhibitors, for example.
Right, exactly.
So both can be approved and both can be used in a same patient.
Oh, I don't disagree with that. In fact, the interesting thing was there were two compounds that were being developed parallel, ASG15 as well as the 22, which is Enfortumab, and they both targeted different antigens. This was nectin. The other one was SLCTRAC4, which is expressed in urothelial carcinoma. For a variety of different reasons, the first one was decided not to go forward with development. But again, the question is, would that drug, since it's hitting a different target, would that drug have activity in a patient who failed or progressed on the 22 compound? We did sequence a couple of patients. We had both phase 1 trials open. Generally, what I saw was stabilization of disease if they had progressed after one. And in fact, we had one patient who was on 15, had massive lung disease, responded dramatically to treatment. In fact, he was on 6 liters of oxygen when he started therapy. Totally stopped oxygen within 6 weeks of starting treatment. And then we got about 6 months out of that. He went on to the other antibody. We got about 6 months out of that one as well. So, and again, his disease was predominantly stable with the second antibody. So, I think again, there's room to really understand the biology here and how it will affect both not only the target as well as the payload.
And what is the risk of myelosuppression with these ADCs?
Excuse me?
The risk
it's really not great. I have to look back at the exact numbers from our toxicity, but we had one of the critiques at the presentation at ASCO last year was there was a high rate of urinary tract infections. Well, that's one would expect in urothelial cancer patients who've got stents who have other appliances. The rate of febrile neutropenia was probably about 3%. It was very, very low. And I'd have to look back at the numbers to tell you exactly what that was.
One quick question. A topoisomerase 1 inhibitor, an SN38, is a very interesting drug to do because it's very schedule dependent, and it's actually the longer you can keep it in the cell. Do they have any data that they have prolonged intracellular concentrations of the vedotin, I guess they called it?
I don't know if they have it or not, but the interesting thing was in thinking back to some of the refractory bladder trials we've done in SWOG, we did have an irinotecan trial a number of years ago, and I think it was 2 patients short of going to the second level of accrual. We had I think we had 2 responses short of further. So there's activity of these drugs, but the question is, is it concentration or other issues?
Yeah, you can improve the pharmacokinetics of that drug by giving it that way. So.
Exactly.
Okay.
Good.
Thank you.
Terrific. Thank you.